Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of having on the podcast my dear friend and colleague, Dr. Fred Amant. He is the one of the authors of the new guidelines, the ESGO INCIP guidelines for the management of patients with gynecologic cancers during pregnancy. We're really excited to talk to him about some of the new features of the guidelines and the details related to it. Obviously, it's always a topic of great discussion when we see patients who are diagnosed with a gynecologic malignancy and also happen to be pregnant. So who better to speak to this about this topic than a leader in this field, Fred Amant. Fred, welcome, and thank you so much for accepting our invitation.
Well, pleasure is mine, Pedro. And when I received your invitation, I didn't hesitate any single moment. So it's really a pleasure to be here and to share with you some, thoughts on the new guidelines.
Fantastic. So, Fred, let's start by let's discuss how did you and the team come together to organize these guidelines? And I see, obviously, it's a large team. So, love to hear how you all came together.
Actually, there was a lot of preparation online, and we physically came together on one occasion, and even that was actually a hybrid meeting with some people, actually those who were responsible for certain chapters who came physically to Leuven in Belgium, and others actually attended online. So we actually all came together once, but of course in the preparation we had many online meetings. But we felt that even in the online setting that a physical meeting was actually very important, crucial. And it was actually very important, for example, to make the flowcharts. And you can discuss about a lot, but to make a flowchart online, that is virtually impossible. So we are very happy, honored and proud on these flowcharts that are clinically very directive. And to be physically together actually was really a need necessary to build these flowcharts.
Fantastic. So, Fred, as you know, we often have questions from our fellows in the journal. This first question is from the fellows from Frédéric Amant, and she's in Heidelberg University Hospital in Germany. And she's asking, since the previously published guideline in 2019, what are some of the things you would like to highlight that are definitely new or have changed since that time?
Well, first of all, I like the concept of asking young colleagues to have a look into it. And I think this adds to very interesting questions like this first one. Of course, there are many changes, but to highlight some of them, I think the new guideline is just better than what we did before. And the reason why it is better is also the fact that we followed the ESGO developmental process of actually making a guideline that starts with the nomination of the experts actually. Then we collect the scientific evidence. Then we formulate with all the group, the different guidelines. But then, and that is something we did not do before, this external evaluation by external reviewers, and those comments are actually integrated. So that process is actually novel and adds to better guidelines. And then also every guideline, I think for the readership, I think it's very important to realize these levels of evidence and these grades of recommendation that are present in all the ESGO guidelines. I think every recommendation on its own actually does not say so much. I think you only can really integrate it in your clinic is the level of evidence and the grade of recommendation. And that is something that was absent actually in the previous 3 guidelines, and that we, thanks to ESGO, we worked on that. If you look to the content, I think, also it's the first time that there were patient representatives present, and they really shape the guideline from their perspective. And I think that is also definitely an added value in these new guidelines. So basically many things changed thanks to this. And if you have to pick out one that really and changed or is different, is the abdominal shielding. wherein actually in all the previous guidelines, it is written that during imaging, we need to shield and to protect the fetus from radiation. Actually, there is now good evidence that this is actually not needed anymore, and basically is actually worsening it, because the shield itself, so inside the body, there will be some radiation that goes to from inside, so internal scatter that goes to the shield and comes back into the fetus. So that is one thing that changed, and I think it's very, actually what happened till now is that this was done already by radiologists, but the clinicians always said, listen, this patient is pregnant, you need to cover the pregnant, the belly. And then there was this discussion between the patient and the radiologist was not doing what the patient was told should happen. So we wanted to, I mean, this guideline helps to get done with this discussion between the patient and the radiologist. So I think that is something that we really need to change. Also, we in our team, we already applied it, but we now see this evidence. So I think that is very important change with regard to the previous guideline.
No, that sounds great, and I love the the external evaluation and patients also being involved and exactly as you mentioned with this last point, exactly the reason why we have these guidelines is to set aside some of those older principles that we had in place. So I also noticed you started with some general recommendations, and I like that. What are some of the things you would like to highlight before getting into the very nitty-gritty details about the general recommendations?
I think one of the highlights, and also what was different with the previous one, is actually the emphasis that we put on the prevention of thrombosis. Actually, this is a bit neglected, and it was never part of the guidelines. And now, well, we do believe that, I mean, we have risk factors, which is cancer and the pregnancy and sometimes the surgery. So if there is any combination of these, we should actually prevent thrombosis. There are data that our patients actually suffer more from thrombosis. So we really should pay much more attention to that. And that is definitely something that we added in this guideline. We have also these risk factors that we added apart from surgery and pregnancy. Yeah, so I think we can really fine-tune the need for antithrombosis treatment. So I think that is very important and new. I think something else that came out during recent years is that the risk of local thrombosis by a peripheral catheter is actually more in pregnancy. That's why in cases we use chemotherapy, a portacut is actually preferred. That's also very novel. And I think what we always need to emphasize is we really need experts. We need a multidisciplinary team that is on board, including the perinatologist. Still too frequently, we see that decisions are taken by oncologists and who do not really understand the risk of a baby that is born at 28 weeks. Of course, this baby is viable, but the long-term consequences of prematurity should not be neglected. And I think in all the discussions, they should be on board. So I think those three, the thrombosis, portacut, and then really experts. Cancer during pregnancy is most of the time not an emergency. There is really time to get this multidisciplinary setting and to look for that and to look for the appropriate experts. I would say that these are the recommendations that we want to highlight from these new guidelines.
Great. So back to the topic of imaging. Filippo Capomacchia, he's at Candiolo Cancer Institute in Italy. He's asking, in which clinical scenarios do you consider essential to supplement the initial evaluation of a pregnant patient with gynecologic cancer by performing abdominal and thoracic CT scans rather than depending exclusively on MRI and ultrasound?
Yeah. Okay. Yes, indeed, because in the new guideline, we favor, of course, the image or modalities that do not use ionizing radiation. And so we favor MRI. We can do a whole body MRI, pelvic MRI, and of course, the expert ultrasonographies. Actually, CT scan of the thorax and even of the abdomen and even PET scan are actually possible during pregnancy, especially if you use low dose PET and CTs, but on the other hand, in most of the cases, they are not necessary. So I would say that CT scan is there's only a place if MRI is not available, or if the expert is not available, or if the sonographist is not available, then this is really a plan B. I think in many centers, actually, if you have MRI and ultrasonography, there is really no need to do a CT scan for these patients.
Great. Now, I also noticed that you place a lot of emphasis on the importance of having an expert pathologist when evaluating pathology in a pregnant patient. Can you talk a little bit more about that?
Yeah, of course. Indeed, actually, it is from two sides. Also, we have to inform the pathologist that the patient is pregnant, and then the pathologist indeed can have a look on that. And I think there are two aspects here. There are always subtle differences actually induced by the pregnancy that the pathologist should be aware of, and that can be details, but for the pathologist it is important. The other thing is that if you have an ovarian mass that is removed during early pregnancy, there are some cases where a physiologic mass actually can mimic a cancer. And we call that in the text the pseudo-neoplastic lesions of the ovary. So I think in that particular case, we definitely have to tell the pathologist that the patient is pregnant, because it can be a physiologic mass. For example, it can mimic sometimes a granulosa cell cancer. So if we then don't mention that the patient is pregnant, then the pathologist could say this is a juvenile granulosa cell tumor in a young patient. So that is one of the examples. So it is mainly also in ovarian masses themselves that can be physiologic masses that the pathologist should really be aware of it.
Okay. Now, Natalia Tejeda from Hospital Clínic de Barcelona in Spain, she's asking about surgical procedures. She's asking, surgical procedures during pregnancy present unique technical challenges that may require adaptations to routine protocols to optimize both maternal and fetal outcomes. Can you elaborate on specific modifications you recommend? For example, adjustments in the pneumoperitoneal pressure, patient position, support placement. Can you speak a little bit about that and how this depends on gestational age?
Yeah, that's a very important question. I think one of the I think when we look into surgery, we have actually a lot of experience with surgery in pregnant women. I mean, most pregnant women are operated for non-cancerous lesions. So there are many surgeries, appendicitis, cholecystitis, or traumas, and so on and so on. So there is sufficient evidence on that. With regard to gynecological procedures, I think the left lateral tilt position from 20 weeks gestational age on is very important. And if the patient is in the supine position, then the pregnant uterus will give some pressure on the inferior cava, and the cardiac preload will actually be insufficient, and the patient will actually have insufficient cardiac volume. So from 20 weeks on, and actually for singleton pregnancies, and 16 weeks from twin pregnancy. So it really depends a bit also on the gestational age. So, and then if you put the patient at the left lateral tilt position, the blood or the oxygenation will be fine. And if you take care for the mother, you will take care for the baby. That's one aspect. From technical point of view, during if we talk about laparoscopy or even endoscopy, I mean robot surgery, the placement or the insertion of the trocar should occur by open surgery. So actually to open the peritoneum under direct view. There are cases of a varus needle that is inserted in the uterus and provokes a bleeding, and the patient loses the pregnancy. So this blind varus needle placement is really forbidden during pregnancy, even in early in pregnancy. So it's open introduction. That is crucial. We use the umbilicus, but if the pregnancy is more advanced, you may even have to go higher than the umbilicus to have the first trocar inserted. And then the adaptations of the other trocars depend also on the volume of the uterus. So we have the normal positions. During pregnancy, you will have to put all these extra port sites actually at a higher level. And that is difficult to really go into detail, but you should look actually to the volume of the uterus and then see that your trocars are far enough that allow you some manipulation actually during the surgery. So that is very crucial. Also try to avoid manipulation of the uterus. Every manipulation of the uterus will add to contractions maybe and will increase the risk of preterm labor. So that is also quite crucial. I think those are the most important. Regarding to the pressures, we use the same pressures. There are very little data to say what level is safe and what kind of duration is safe. There is one paper that said till 90 minutes and duration there were no problems, but that does not mean that if you go further or have a longer surgery that this is not safe. So actually we said in the guideline we did step away from the single study. And we say, I mean, try to work as quick as possible. There is not really a final or a safety period, let's say like that, but try to work as efficient as possible and try to monitor the mother very well.
Fred, since we're on the topic of the OR in surgery, at what gestational age should one absolutely recommend fetal monitoring intraoperatively, and what should be the frequency of that monitoring during the surgery?
Yeah, that is a difficult one. It depends also a bit on the local practice. Actually, from what gestational age on will you actually go for the baby and bring the baby to the neonatal intensive care unit? So in some centers that will be 24 weeks, in the others it will be 25 or 26. So I think that is more or less the area on which you would do that. And then how actually. It's a very interesting question that we always said you have to monitor during pregnancy, but we have all done it. And when we ask around our experts, nobody actually ever had a problem with it. So we are starting to question whether this monitoring is really necessary. So that's why we put it in a guideline. It can be considered, while previously we said it has to be done. And then, of course, it depends a bit on if we do pelvic surgery, we only look to the heart tones at the start of the surgery, and then at the end, we don't do it during the surgery. If you stay away from the abdomen and you do upper abdomen surgery, you can monitor the patient continuously. But I know centers where they don't monitor at all because they say the baby goes well. We never saw a problem. So it is something you can discuss with the patient, and there is still some freedom. So let's say we are more and more moving from a monitoring that deemed was necessary, that we now say it's more like an option. So that's also one of the important changes actually that we see during the last years, because we are operating more and more, getting more and more experience. And as you said from the beginning, that's a good thing. We also want to step away from what we used to do, but what was not so well documented, but we did it because we thought it was needed and it was quite logic. But now we learn from it and we see that babies are not suffering, and nobody actually had really to do an emergency cesarean section for a baby that was in fetal distress. Maybe we didn't cover all the cases, of course, but if you ask it to the experts and if you do it in good hands, the surgery in the safe conditions, then probably the fetus do well.
Oh, good. So now onto the subject of lymph node evaluation. So this comes from Sofia Bigardi in Padova University Hospital in Italy. And she's asking your recommendations. Sentinel lymph node mapping is generally not advised during pregnancy due to safety concerns with the tracers. Given the limited but emerging data on the use of ICG in pregnant women, do you foresee a role for ICG-guided sentinel lymph node biopsy in select cases, or should systematic lymphadenectomy remain the standard during pregnancy until more data is available?
Well, I think Natalia and Sofia read our mind, and that's because they're completely right. The traditional traces are actually not safe during pregnancy, and I think this indocyanine in green is so good. There are some case reports, and we are building on a series. We have now a series of 10 patients retrospectively, and we are actually building on a prospective series. And I think that is what actually our young colleagues suggest. I think this is so good and probably it works very good, but we just need some more documentation. So I would recommend those who want to do it. I think please do it and take contact with us that we can merge all the data into a larger series and then we have more evidence. But in all likelihood, this ICG will be the future for our pregnant patients, not only the non-pregnant patients, but also the pregnant patients. And so far that we used it in those 10 patients, it worked very well.
Excellent. Back to Filippo Capomacchia. He's asking, based on what evidence do you recommend avoiding staging surgery for a pregnant patient with early stage ovarian cancer beyond 18 weeks gestation?
Yeah, that is indeed a very good question as well. Actually, there is not good evidence on that. So it was well noted from Filippo. But the reason is that at a certain gestational age, it becomes difficult to explore the pouch of Douglas, to take biopsies and so on, without manipulating the uterus too much. And it was decided, and of course, this 18 weeks, it's one moment, but around that period, let's put it like that, it becomes difficult to explore actually the pouch of Douglas and the lower part of the pelvis. And then maybe it's better to stay away from there to respect the pregnancy. And then not do these staging operations or these debulking operations. The same is for debulking. You cannot debulk. You can debulk the upper abdomen during pregnancy, but then not the lower part of the pelvis. And then we don't like these incomplete debulkings and then going back and especially exposing the pregnant uterus or a pregnant patient to debulking with all the blood loss and so on. So maybe it's to stay away from there during pregnancy and do that after delivery. And I think the access of the pelvis is actually crucial here. And of course, maybe sometimes you could say 19 weeks. So again, this 18 weeks is like, it is about in that gestational period that actually we should stay away. But I agree, there is no evidence that on 18 weeks itself, we should not do it, but it's to give an idea.
Okay. So now Sophia Bigardi takes us to another important point, chemotherapy. She's asking, given the recommendations on chemotherapy timing, avoiding treatment before 12 weeks, stopping 3 weekly regimens by 35 weeks, and weekly by 36 weeks, how do you counsel patients on balancing fetal maturity against the urgency of maternal cancer control?
Yeah, that's something that indeed we did not detail very much in the guideline, I think, but the practice is, or how we counsel our patients, is that we can make a plan. And the plan is we give chemotherapy in order to have a good response or at least to stabilize the disease. And we also have to look for the baby. And you can make a plan, but the main message here for clinicians is that we have to prepare our patients well that this can change. And depending on the response of chemotherapy of the tumor on the chemotherapy, on the fetal well-being. So we can have a plan, but we should be flexible enough to step away from that, depending on the results or depending on the tolerability of the fetus on the chemo and the response of the tumor on the chemotherapy. So we really request some flexibility in the patient's mind, but also the whole team. We need to have a plan, but we should carefully look into it and be prepared to step away from it. And I give you an example. We can give chemotherapy for cervical cancer, and we have these cases where we do this 6-weekly MRI and the tumor shrinks, but then suddenly we see that the tumor starts growing again. Of course, that is then a moment that we say, okay, now we are getting into trouble. We need to take decisions and we have to stop the chemotherapy. Another example is that we follow the growth of the fetus during chemotherapy. And we know the sooner you start with chemotherapy and the more chemotherapy, the more the babies will suffer. I mean, the growth will decrease and they will grow insufficiently and you will have some growth restriction. And that is very difficult to predict. So also we tell the patients, listen, we look carefully into it, but from the moment, and we continue as long as the baby supports the treatment. And then the patient know that there might be a moment that the baby does not support, and then we have to change it. And so the policy is to give chemotherapy until fetal maturity, as long as this is possible, and as long as the chemotherapy is working and the baby is supporting the treatment. So it's a bit different with regard to other cancers, where we can say, listen, we give you 6 cycles of chemotherapy and things are done. Now here we have to say, we will start and we will see where we get.
Yeah, very well. Mariana Carvalho Gouveia from Sao Paulo in Brazil wants to take us specifically to the management of patients with locally advanced cervical cancer. She's asking, systemic therapy can be started after 1 week following cesarean delivery or a few days after vaginal delivery. For patients with locally advanced cervical cancer that will need definitive treatment with concurrent chemoradiotherapy, how long after the delivery should this be initiated?
That's a very good question because it's indeed not in the guideline. So we'll have to incorporate this one in the next guideline. Well done, Mariana. Well, I think in those cases, all the patients will have a cesarean section because one of the contraindications for a vaginal natural delivery is cervical cancer that is in situ. So all these patients will have a cesarean section. And then I think we start chemotherapy after 1 week. I think after 1 week, we can start preparing the radiation as well and get all the imaging modalities. Of course, the cervix and uterus, they may still shrink. So then we need some adaptive radiotherapy to take the decreasing volume after the pregnancy into consideration. So that's something that radiation oncologist will take into consideration. So, but I think after 1 week, we can start preparing all these things. And then maybe, I mean, that takes some time as well. And then maybe after 2 weeks, we can really start with the radiotherapy.
Yeah. And a follow-up question from Mariana. Again, of course, obviously, same patient population here. She's asking, with emerging data from the Interlace trial on induction chemotherapy, do you see a future where weekly paclitaxel carboplatin becomes the preferred regimen during pregnancy for locally advanced cervical cancer, not only for its efficacy, but also as a strategy to delay definitive chemoradiation and reduce the risk of iatrogenic prematurity?
Yeah. Yeah, certainly. And actually, it is already part of the guidelines so that we allow weekly chemotherapy. We don't have we had insufficient data to have a favorite, but we allow 3 weekly, or we suggest 3 weekly or weekly schedules. I think if you look into our community, we use for ovarian cancer in the non-pregnant population. I mean, there are centers use weekly Taxol carboplatin, others use 3 weekly. I think the same will actually occur in other cancers, and in our population as well. We use it actually in Leuven, where we use this weekly schedule already. It allows a close follow-up. You can close follow-up the monitoring of the baby. Patients have less side effects. Of course, they have to visit the hospital a bit more frequent, but especially in a pregnant situation, I mean, having 3 weeks that you don't see a physician is quite a long time. So I think this weekly control checkup by the obstetrician and by the oncologist is actually something, it's not too much, basically. So summarizing the answer, I think, yes, I think the future is more likely to be a weekly schedules in this population.
Okay. This next question comes from Helena Obermeyer in Westmead Hospital in Sydney, Australia. She's asking, the guidelines suggest assessing cervical competence prior to each chemotherapy cycle during pregnancy. Can you explain the rationale for this recommendation and share how it influences your management?
Yeah. Actually, if you look at a large series, we see that the incidence of preterm rupture of membranes and preterm delivery is a bit higher in patients that receive chemotherapy. The problem is we don't know exactly why this is. We only see that it happens, and we don't have a clue that we say this is now I mean, there's no one chemotherapy that actually more risky for this obstetric complications. So that's why in our population we monitor it. In most cases it is fine, but the consequence, suppose that our obstetrician says, listen, this cervix is really shortening. Importantly, we make an assessment on each individual case to see what is the risk and what is the gestational age. And if the risk is too much, and we can, well, we can say, listen, now we stop. We don't want, maybe we take a pause or we induce a delivery depending on the situation, but it's not safe anymore, or to continue with the chemotherapy. That's actually the clinical consequence. In our clinic, the patients get an obstetric consultation the same day. They first go to the obstetrician, and after an interdisciplinary discussion, and when we see that the baby is doing well, there is no imminent prematurity, then we give the chemotherapy. For example, what we don't want is that a patient gets chemotherapy and then 1 week later on she delivers, because then maybe the platelets may be low, leukocytes may be low, so there might be risk for bleeding or infection and so on. So this imminent preterm delivery is quite important. That's why this assessment by an obstetrician or a perinatologist is very crucial. And they should really work together. And then if we talk about safety and so on, it is on this condition that this is safe and this is well managed. And that's why we believe it's important.
And can you speak now about breastfeeding while undergoing therapy with chemotherapy? Is there any point during the treatment that the patient may safely breastfeed? How about if a patient is receiving radiotherapy alone, can they breastfeed?
Okay, I'm very glad with this question, and I'm very glad because we wrote in the guideline that actually breastfeeding and chemotherapy cannot be combined. But I think the problem is that we don't have enough evidence to put it into a guideline. What we have seen in our studies is that actually chemotherapy after 72 hours, the volume of chemotherapy in milk is actually very, very, very low. And I'm confident that actually after 3 days, you can breastfeed with chemotherapy. The only exception is with cisplatin. That really remains a longer time into the milk, but we don't use cisplatin so much in the pregnant population. The only reason why we didn't put it in the guidelines is that we actually have insufficient evidence to really allow it. But yeah, that's why because we just have insufficient evidence. But to give an answer on a colleague, I think, yeah, after 2 or 3 days, maybe then you have to disregard that milk, and then you can actually breastfeed the child, especially in countries where there is no product, formula milk, and so on and so on. I think this is a very important message. In other countries, of course, the milk can be replaced by formula milk, but not in all countries. So there, I think, don't use the milk immediately after the chemotherapy, but then afterwards, probably the milk is good. We don't know if the quality of the milk actually is the same to the chemotherapy. Also, that is something we don't know. But I think if that is the only thing, then I think the children will not suffer from that. Regarding radiotherapy, I don't see a reason why this cannot be combined. Radiotherapy and breastfeeding are possible. It brings us to another topic. In an irradiated breast, if you talk about breast cancer, which was not a topic of the guideline, of course, an irradiated breast will produce much less milk when compared to a non-irradiated breast, but you can breastfeed from the other heterolateral breast, of course. So I think in breast cancer survivors, I think also breastfeeding from the non-affected breast is actually possible. The affected breast after radiotherapy will produce less and maybe no milk, depending on the situation.
Yeah, really important information. This next question comes from Luisa Prope in a University Hospital in Münster, Germany. How might advances in molecular diagnostics and targeted therapies impact the management strategies for pregnant patients with gynecological cancers in the coming years?
Yeah, actually, that is the question of the future. I think that is the challenge actually that we have today. We have all these novel drugs, and actually none of them has been tested in pregnant women. We don't know actually what really goes through the fetal compartment. And if we touch that topic, drugs that of the transplacental passage will depend on the volume of the drug. Is it a large or small molecule? Is it hydro or lipophilic? It will depend on receptors in the placenta. For example, immunotherapy is dependent on receptors, and the number of receptors increases as the gestational age increases. So immunotherapy actually crosses the placenta much more in the as pregnancy advances. And actually immunotherapy is safe during the first part of the pregnancy, which is completely the opposite of chemotherapy. So, I mean, and then so if a drug is transported by a receptor or not, that also then will make sure or lead to a safe or a non-safe drug, especially if then antibody-based therapy. So if we talk about the ADC drugs, then it will depend, of course, on which antibody or which target are you looking for. If you then, for an example, the HER2 drug, we know that anti-HER2 drugs are actually toxic, or actually they can influence actually the fetal urine production. So, and that leads to anamnion and to respiratory distress, and babies may die from it. So, of course, the ADC targeting the same target will also not be safe. I mean, I don't have data on that, but I can predict that it will be like that. So I think if you talk about an antibody, it will really depend on what antibody is it and what is actually the function of that target in the fetus. And that together will determine whether it's safe or not. But yeah, we have so many new drugs, so many new antibodies that we really have to individualize this very properly. And it will be very difficult to have series of use during pregnancy and to document safety or non-safety. So I think that is one of the big challenges in this field, actually.
Fantastic. So, Fred, I want to be respectful of your time. I have two more questions. This one is, the guidelines recommend registering all cases in a cancer and pregnancy registry. What do you see as the most critical gaps in the information that we have now? How can we best leverage the registry to address these gaps and improve care for both the patients with cancer and their children?
Yeah, I think that's an excellent question, because in the registry, we have more than 3,000 cases already. So what is then the added value of new cases? I think the critical gaps is, for example, I mean, less common cancers. We have a lot of data on breast cancer, and I think nearly half of the cases that we registered are in breast cancer, and the evidence on the safety of the drugs, the prognosis is actually excellent. But many cancers, I mean, we have only 10, 15. I mean, the series are just much smaller. So I think that is one advantage or one neat gap that but as said in the previous question, also about these new drugs. So if we want to have some series of effects about in the mother and in the child on the drugs, we need larger series to document all these newer drugs and novel treatments. So I think that is the critical gap. You can start questioning whether we still have to register breast cancer cases. I agree on that. But on the other hand, also in breast cancer, there are novel drugs that are used. So still, if you want to cover these, then you have to continue to register these. So I think that is the most critical gap. Rare cancers, and then the tsunami of new drugs that more and more will be used during pregnancy as well. And if we want to get information on that, we have to continue to register actually all cases.
Yeah. And Fred, as the last question, as we typically ask the primary authors of the manuscripts that we're discussing, what do you do in your practice? So what are the three most important points to consider when you're counseling that patient that comes to you pregnant with a gynecologic malignancy?
Yeah, that is challenging. So I'll try to summarize this briefly. I think we started this project on cancer and pregnancy 20 years ago. At that moment, we had so many open questions. And I think we have to tell the patients that last 2 decennia, we learned a lot. And one of the key things that we learned is that despite the counterintuitive feeling that chemotherapy is not safe, we have to say, listen, chemotherapy is safe. We can give it under certain conditions, but pregnant women can't drink alcohol, they can't smoke, they have to take care about certain drugs, they can't eat raw meat, and they can't eat or they have to wash vegetables very well, and so on and so on. And then, so we have to show them, despite all these important precautions, chemotherapy can be given, and thereby we respect your chances for cancer treatment, and we respect the right of the life of the baby. So I think to reassure patients on these results is important. The second topic, I think, which is important, is what I already said before, this flexibility, that you can build on a treatment trajectory, but it will, we have to take the tumor response into consideration, but also the fetal monitoring into consideration. And one of these unexpected outcomes, which can happen, actually will further determine a change in this treatment plan. So this, flexibility is something that is important, and people can handle it, but they have to know that it can change. I think the worst thing we can do is, listen, it is like that, and then afterwards, no, we change the plan. If we tell them that the plan can change during time, patients are flexible into that. And I think the third important item, I think it's uncommon, let's put it like that. and we have not many people who really have a lot of expertise. So we really need expert centers who refer the patients, ask for a second opinion, and think. And when this is available, I think we care best for mother and child. So I would say that reassuring the patients about the safety of the cancer treatment, a flexible mind, and expert centers. I think those would be my three main recommendations and points to consider.
Well, Fred, thank you so much. Always such a wealth of knowledge, and such a pleasure speaking with you. I think, we as gynecologic oncologists really owe you a debt of gratitude for all that you have contributed to the field. You really are a leader in this area, and most importantly, so many women and so many children who have benefited from your research and your work. So my hat off to you. Thank you so much. I look forward to the Journal Club where we can discuss this further. And thank you for the invitation, for accepting our invitation to the podcast.
Pedro and your team, thanks a lot for giving me the option to share this with you, and thank you for your grateful, warm words. I really appreciate it. Thanks.